Did you ever think that gingival grafting would be a controversial subject? In dental school, in my residency program, I was always taught if there's recession, we graft. But that's not really true. Grafting does make a difference. Patients that have had their teeth grafted are less prone to recession. Patients that have had their teeth grafted are less prone to having more inflammation around those. The literature has brought this out over the years. When I was first in my residency program, we were taught by Lang and Lowe that we needed a minimum of 2 millimeters of keratinized tissue around every tooth. Is that still the case? Probably not today. How about implants? Do we need keratinized tissue on implants? Well, when implants were first being done, we never talked about keratinized tissue or the necessity for it. However, you have keratinized tissue around dental implants, they're going to be less sensitive, they're going to be less prone to recession, and they'll probably be less prone to periimplantitis. So I think keratinized tissue on implants is very important. Now, what causes recession? Probably the biggest cause of recession is just a genetic predisposition for it. You have thin bone, so you're more prone to recession. I would say maybe an offensive lineman that's 300 pounds and 6'2" is not going to be prone to recession because they have a different bone type. I very rarely see recession in those type of patients. People who have thicker bone are going to have less recession. But if you have thin bone or a thin biotype, you're going to be more prone to recession. Now, what other reasons cause recession? Overzealous toothbrushing. Orthodontics, moving teeth through bone, will definitely lead to recession. If you move the tooth through the alveolar bone will be lost and you have recession. Recession is due to bone loss. So when I say recession, I think about bone loss, a thin biotype, lack of alveolar bone. Caries can lead to recession. All right? Periodontal disease can lead to recession. Iatrogenesis can lead to recession, invading the biologic width, utilizing electrosurgery too close to the bone. Utilizing even lasers, if there's too much jewels in there, that can lead to recession. And of course, patients can lead to recession with, snuff or, having a tongue ring or something like that. Now the question is, these are causes of recession. So when do you treat? Do you treat if there's no attached gingiva? Well, it's not a bad indication to treat because the recession will get worse, especially if the patient has inflammation associated and sensitivity, and the recession is getting worse over a period of time. So one of the things I recommend that you do in all of your patients is that you take clinical photos on all of your patients, digital photos at the initial visit, and then maybe once a year. You'll see a trend. Maybe the recession is 3 or 4 millimeters, and a year later it's still 3 or 4 millimeters. However, as I saw yesterday, I had a patient that had 3 or 4 millimeters of recession. I treated her with a couple of implants when she was 27. She returned yesterday. She's 37. It's been 10 years. That 3 to 4 millimeters of recession is now 7 millimeters of recession and is inflammation. And her teeth have also shifted. So she had a shift of her bite. She now has a cross bite where the lower canine is buccal to the upper canine. So that means the tooth has moved through bone and it's now out of the vestibule, difficult to clean, there's inflammation, and that's a true indication for grafting. But that's one where she has inflammation, a vestibular problem, and a tooth positional problem. And she's only 37, and she's about 7 millimeters from the apex. So that might be a reason to treat, increasing inflammation and increasing loss of attachment. Other reason to treat is prior to ortho. If you're going to be putting a patient through orthodontic care and they have a significant recession, a very thin biotype, you might want to augment that prior to ortho so that they don't lose bone during that period of time. You can do that with connective tissue grafting, with free gingival grafting, which is one of my favorite grafts to do, and bone grafting in conjunction with connective tissue grafting. Prosthetics. If someone's going to have a prosthetic rehabilitation, you want keratinized tissue around the teeth. If they're going to have an implant reconstruction, you'd like keratinized tissue around the teeth. If patient has sensitivity, that's an ideal place to do connective tissue grafting if fluoride doesn't work. I would rather do that than put a class 5 restoration in the areas of sensitivity. And a lot of dentists don't realize this, but you can cover roots with connective tissue grafts. Matter of fact, you can remove a class 5 restoration, clean the root, get right down to dentin and or cementum, and do a connective tissue graft on a root that previously had a restoration. Now, what will connective tissue attach to? It will attach to dentin, it will attach to the PDL, it will attach to cementum, it will attach to bone. It will not attach to enamel. Connective tissue won't attach to enamel, and it won't attach to a foreign body, like a piece of titanium or gold restoration, or a class 5 aesthetic restoration of some bonded material. However, if you remove caries and you get right down to dentin and or cementum, you can do a connective tissue graft. Another reason that we do a lot of grafting in our practice is aesthetics. People don't like the recession, so I can show them where we can move the tissue. And today we have procedures that are pretty predictable. We have connective tissue grafts utilizing autogenous tissue. We have connective tissue grafts utilizing allografts like a purus dermis, which I frequently will soak in Gem 21 prior to grafting it because it recruits blood vessels to move into that area. And we get very good root coverage and results with that. I also use autogenous tissue for free gingival grafts. We also have xenografts, from pigs. Like mucograft or fiber guide. Those areas can also be used in conjunction with flaps to do connective tissue attachments. So there are a lot of different alternatives out there, and every week there seems to be another alternative. But the tried and true one is the free gingival graft and subepithelial connective tissue graft, which have been around for 40 and to maybe 70 years. The connective tissue graft, the free gingival graft, was developed back in the late 50s. And then, of course, there's the shallow vestibule where a patient can't brush because there's no room. So you can do vestibular augmentation, do a free gingival graft in that area. And again, abfractions I would not treat with class 5 restorations. As my colleague and mentor, P.D. Miller, says, I'd like to drive a stake through the heart of every class 5 restoration. And the reason he says that is because once you put a class 5 restoration close to the gingiva, you can redevelop the biologic width. And guess what? You don't prevent recession, you actually increase it by doing class 5 restorations. So if we do class 5 restorations in our practice, we make sure that the gingiva is healthy and we have an adequate band of keratinized tissue. Now, what is an adequate band? It's nice to have 2 millimeters of keratinized tissue. And what the literature shows is if you do have keratinized tissue, you're going to be less prone to recession. That doesn't mean that you have to graft everybody that has recession, but you do need to know the literature and what works. And subepithelial connective tissue grafts, while they may look good right away, there is some recession with those over a period of time. With a free gingival graft, once you place it, they're 100% successful because they will stay. And when there's something called gingival creep, where the gingiva will actually move incisally and the tissues will look better over a period of time. So there's a quick overview of my philosophy on when do I treat, when do I not treat. So when do I treat? I treat after a conversation with the patient about the pros and cons of treatment. Teeth aren't going to be lost immediately if they're not grafted. It's not like having caries in the tooth. If you don't take the caries, you're going to need an endo, and then you may lose the complete tooth eventually. And with periodontal disease, untreated periodontal disease will get worse without treatment. That's sure. We're not sure how fast it's going to get worse, but it will get worse unless you treat it. Gingival recession may get worse, may not get worse. That's why documentation is so important. So hopefully this was a good overview for some of you. Some of you know all this already. And those of you who don't know it, listen to it again. Just go over why am I treating and think when you're working with a patient, is this the right treatment for this patient? Does it need to be done? Or am I just having a knee-jerk response because I see recession, I want to treat it? That way you can truly be the gift to your patients. Have a great day, everybody.